as we go. So without further ado, I want to introduce Dr. Lynne Mofenson. Many of you know her. She has worked tirelessly at the National Institutes of Health from 1989 to 2014 and was responsible for program planning and the development and scientific direction. Excuse me? Excuse me? Hello?
Yeah, we're here, Jessica. I think somebody just spoke up.
Okay, sorry. So Dr. Mofenson, as I was saying, was responsible for the overall program direction and scientific research studies and clinical trials in domestic and global pediatric, adolescent, and maternal HIV infection. And currently she is the Senior HIV Technical Advisor at the Elizabeth Glaser Pediatric AIDS Foundation. And we're truly pleased that she has agreed to host and curate this webinar, which is a scientific summary of the latest evidence and science that was presented at the International AIDS Society conference that was held in Amsterdam in July 2018. And it's become a tradition that she has generously shared all of her synthesis of all of the latest research, both at CROI and at IAS for the past few years through our Learning Collaborative. So we're delighted to have her here today. And the webinar will be a little bit over an hour, and we'll have some time for questions and answers afterward. But feel free to type in your questions as we go, and we'll get back to them. So without any further ado, I'll hand it over to Dr. Lynne Mofenson.
Thanks, Jessica. Can you hear me okay?
Yes, perfect.
Okay, good. There's also a larger slide set that UNICEF can make available to folks that have some additional presentations. So this is a selected group of presentations from the pediatric workshop and the IAS meeting that was held, I think it was 2 weeks ago in Amsterdam. And pretty much the main subject of the meeting, other than U equals U, is everything dolutegravir. And I want to briefly mention 2 studies in adults. The first study came from the Brazilian Ministry of Health, and they used national antiretroviral prescribing and laboratory data and looked at 6-month viral suppression rates comparing between different regimens in adults, and found that a dolutegravir-based regimen was 42% better at viral suppression at 6 months than efavirenz, and more than 50% better than a variety of different protease inhibitor treatments, with the only caveat here being that this is an early viral suppression, 6 months, and one would expect that a protease inhibitor, which has a rapid viral decrease, would be better at 6 months. The second abstract was looking at 5 clinical trials in over 3,500 patients and looking at neuropsychiatric symptoms, and they reported that these were similar in adults receiving dolutegravir and non-dolutegravir regimens, so that side effect doesn't appear to be specific for dolutegravir. So moving to studies of dolutegravir in infants and children. The first study is from P1093 from IMPACT. This study initially enrolls a mini cohort for safety, a full cohort that does intensive PK, and then they enroll some more patients to look at more long-term safety. And we're going to focus in this on the younger cohorts. Cohort 3 is 2 to 6. Cohort 4 is 6 months to 2 years. Cohort 5 is greater than 4 weeks to less than 6 months. And they enrolled 30 per patients, 10 per age cohort. 53% had RNA greater than 50,000. And on the slide, you can see the weight band-based dispersible tablet dosing that they looked at in 5 milligram increments. And so the first look is at viral load response. So this is looking at week 4 viral load response, and responders defined as going to less than 400 or at least a 2-log drop are shown in red, and non-responders who stayed greater than 400 or had less than a 2-log drop are shown in blue. And at week 4, 80% of the 30 children had already had an RNA less than 400 or a 2-log drop from baseline. This looks at the PK parameters by age, and you see cohort 2, 3, and 4 going from oldest to youngest, and the bottom row shows you the adult target ranges, and you can see that for almost all the parameters they were similar in adults and children, with the exception of the oldest cohort where the trough level, the C24, was significantly lower than the adult trough level. And this looks at the trough levels by age cohort, and in the red boxes you can see those that were below the target range. So the 5 and 10 milligram doses in the 4 to 6 month children had similar exposures to adults, but the 15 to 20 milligram doses in the older children, 6 months to 6 years, generally had C24 values that trended lower, and because of that, increased doses are now being assessed, and this is actually to be expected because young children have a very immature UGT1A1 and CYP3A4 enzymes, and these increase as kids get older, so one would expect that clearance would be less in young children and increase in older children. Reason for doing the PK studies. This is also from 1093, but is looking at the older age cohort here who got tablets or granules, and they were looking at viral failure. So if you look, we have the oldest cohort 1, 12 to 18, then we've got cohort 2A, 6 to 12 who got tablets, and cohort 2B who got 6 to 12 who got granules. And you can see that the rates of viral failure were...
I can't see any slides, but I can hear her talking.
Okay. Jess, should I continue?
Kindly place your mics on mute. Thank you.
Okay, I'll continue. So as you can see, the incidence of viral failure was higher for youth who were 12 to 18. 39% had viral failure compared to the younger children 6 to 12, where 1 of 15 or only 7% had viral failure. And viral failure in most of these cases was due to adherence issues. And the concerning thing here was that integrase inhibitor resistance was found in 3 of 19 children 6 to 18, so 16% with viral failure. All of those who had resistance had viral failure due to adherence issues, and there were 2 different mutational pathways that they went through, with one mutational pathway, G118R, having a greater impact on reduced dolutegravir susceptibility. So it is a little bit of concern that if there's poor adherence, that one could end up with dolutegravir resistance in these adolescents. So moving on, excuse me, to studies in pregnant women related to dolutegravir. So the first thing I want to address is when started during pregnancy, when dolutegravir is started during pregnancy, do pregnancy outcomes differ between women getting dolutegravir or efavirenz? And this study actually is published. It's in Lancet Global Health. It comes from the Botswana cohort, and they looked at women starting efavirenz-based treatment in orange compared to dolutegravir-based treatment in green, and looked at a variety of pregnancy outcomes, any outcome, any severe outcome, preterm, SGA, stillbirth, and neonatal death. And I don't need to read the numbers for you. You can see that the bars are very similar, and there was no difference between the 2 regimens. And there was also no difference in major birth defects with first trimester exposure. There was 1 defect out of 395 efavirenz exposures, a skeletal dysplasia, and no defects out of 280 first trimester dolutegravir exposures. So at the meeting, we had the results from Dolphin 1 presented. This is a randomized trial comparing dolutegravir and efavirenz in antiretroviral naive women who are presenting late in pregnancy in South Africa, with primary endpoints being pharmacokinetics and secondary endpoints being viral load and safety. And the way this trial was designed was that everyone started on efavirenz-based treatment, and that in the first 5 days, at a median of 3 days, the patients were randomized to either continue efavirenz-based treatment or to switch to dolutegravir-based treatment, which went throughout the rest of pregnancy and up to 2 weeks postpartum. And maternal viral load was measured, infant viral load, and dolutegravir PK at the time points that you can see. So 60 were enrolled, 29 in dolutegravir, 31 in efavirenz. They enrolled at a median gestational age of 31 weeks. There was no difference in baseline characteristics, and 21% reported use of traditional medicines. So in terms of the pharmacokinetics, the blue bar here is the dolutegravir in 3rd trimester, and the yellowish bar is dolutegravir postpartum. And you can see that there was a modest decrease in dolutegravir during the 3rd trimester in that blue bar, not warranting a drug dose increase, as all but one of the levels were above the IC90 of 64 nanograms per ml. The median maternal cord blood ratio was 1.21, so the levels in the cord blood were 21% higher than in the mother's blood. And breast milk to maternal plasma ratio was 0.03, so there was a 3% penetrance of dolutegravir into breast milk. When we look at maternal plasma versus infant plasma, the yellowish here is the maternal plasma, the blue is the infant plasma. You can see that there were relatively high infant plasma levels at peak 111 nanograms per ml, at trough 87 nanograms per ml, and the infant maternal plasma ratio was 5 to 12%, and this is relatively high for antiretrovirals. And this is likely because there's a slow washout of dolutegravir because of the immature glucuronidase enzyme we talked about before. So it penetrates across the placenta very well, resulting in relatively high levels in the infant. Dolutegravir was associated with a much more rapid viral load decline. The median time, the chart there in red is dolutegravir, blue is efavirenz, and the median time to RNA less than 50 copies was approximately half that with dolutegravir compared to efavirenz. And a significantly greater proportion of dolutegravir than efavirenz subjects achieved viral suppression at the 2-week visit postpartum, 69% versus 39%. And there were 2 viral failures in the dolutegravir arm. Whoa, that's noisy. Okay. Is that me or you?
Somebody who's joined. Please kindly, if you join, place your mic on mute. Thank you.
Okay. So of the 2 viral failures, one was clearly due to non-adherence, and the other one was in a patient who actually had 3-drug resistance from their baseline. So then the most important question, of course, the one that dominated most of the meeting, was when started preconception, do pregnancy outcomes differ? And in order to discuss this, we need to talk a little bit about the timing of in utero antiretroviral exposure and fetal risk. And this slide shows you embryonic development, and underneath you can see the types of teratogenic risks. And the main point here is that the first 2.5 weeks post-fertilization is the pre-organogenic period, and this is generally not sensitive to teratogens. Weeks 3 to 8 post-fertilization is the period of embryogenesis, the period of major organ development, and is the most sensitive period to teratogens. For example, the neural tube closes by day 28, and with interruption here, toxicity here, you can get neural tube defects like myelomeningocele. Oral structures form by day 36, so toxicity here can cause things like cleft palate. And after 8 weeks post-fertilization, you enter the period of fetal growth and development. And examples of problems here include fetal alcohol syndrome with alcohol use after 24 weeks and intrauterine growth retardation with smoking after 20 weeks. And so the major point here is that the greatest risk for serious deficits is not in women who start during pregnancy, but it's in those who conceive while they're receiving the drug. But if you look at the literature, even if you look at the antiretroviral pregnancy, most studies do not distinguish between the first trimester and preconception exposure, which is a problem. I want to talk a little bit about the expected incidence of neural tube defects. So this is a study that looked at the prevalence of neural tube defects globally in 2015, found it was 0.19%, ranging from 0.15 to 0.23%. And of importance is about 50% of the cases were elective terminations or stillbirths. So if you only evaluate live births, you'll get an underestimation of the prevalence of neural tube defects. And there was a nice study published 2 years ago that looked at Africa in specific. They looked at data from 8 countries in 11 studies and found the median prevalence of neural tube defects in Africa was 0.12%, with the range that went from very low to higher. And then this year, at CROI, we had data from the Uganda Birth Surveillance Project, over 43,000 births, over 4,600 to HIV positive women. Now these women were on a efavirenz-based treatment, and the prevalence of neural tube defects here in the uninfected group was 0.09, and in the HIV positive group on efavirenz was 0.04%. So within the prevalence you see in that chart there. So the Botswana study is a birth surveillance study that was originally designed 4 or 5 years ago to evaluate the risk of neural tube defects with preconception efavirenz exposure. And this was actually funded by my branch at NICHD right before I left. And it's a prospective birth outcome surveillance study looking for major surface birth defects in 8 large maternity wards that covers 45% of births in Botswana. They have trained hospital midwives who do a surface exam and put it onto a form. A research assistant, when there's an abnormality found, a research assistant consents the mother for a photo. And there's a medical geneticist who reviews the photos blinded to exposure. And this study has a good denominator with control groups and the ability to distinguish between regimens. So it has an HIV uninfected group and then an HIV infected group on treatment preconception or started during pregnancy. So in this study, they identified 86 neural tube defects in over 88,000 births for an overall prevalence of 0.1%, very similar to what I showed you in the prevalence slide. 42 were meningoceles, 30 anencephalies, 13 encephaloceles, 1 enioencephaly. 57% had photos. Of these neural tube defects, 25% occurred among stillbirths, and among live-born babies with defects, 39% died within 28 days. So when they looked over time during the study, there was no significant recent increase in neural tube defects overall. And you can see in May 2016, the country rolled out dolutegravir as their primary first-line regimen, including for pregnant women. So this graph shows you month of date of conception. So you could see if there was going to be a problem with dolutegravir, it wouldn't be in May 2016. It would be starting 9 to 12 months after that. And you can see that there was a beginning of a problem, which we'll talk about in a minute, in red, with dolutegravir at conception with neural tube defects. There was no clustering by site. These 4 defects occurred at 3 different sites. And when they looked at ascertainment by looking at a minor abnormality, polydactyly, which is in about 1% of the population, they found that was similar between all groups, including dolutegravir at conception. And these are the results that they presented to the WHO in May. Neural tube defects were found in 4 of 426 exposures to dolutegravir at conception for a prevalence of 0.94%, ranging from 0.37 to 2.4. Looking at non-dolutegravir treatment at conception, it was 14 out of 11,300 for a prevalence of 0.12. Looking at the subgroup of preconception exposures that was efavirenz, it was 3 out of 5,787, or 0.05%. Dolutegravir started during pregnancy was 0 out of 2,812. Non-dolutegravir treatment started during pregnancy, 3 out of 5,624, 0.05%. And then finally in HIV uninfected women, 61 out of 66,057 for a prevalence of 0.09%. And you can see that the confidence intervals for these other categories do not overlap with the confidence intervals for dolutegravir. And this graph shows it more graphically. You can see the prevalence in dolutegravir at conception, non-dolutegravir at conception, efavirenz at conception, dolutegravir started during pregnancy, and HIV uninfected. And the prevalence difference was greater than 0.8% between these groups. And you can actually find these data in the New England Journal on the same day they presented this at the meeting. They had a letter to the editor that was published in the New England Journal. At the meeting, they did present an update through July 15th, 2018. There were no more neural tube defects in the preconception group, 2 more neural defects overall, 1 in an infant exposed to dolutegravir starting during pregnancy at 8 weeks gestation, which gives us now a prevalence of 0.03%, which is what you would begin to expect with several thousand exposures, and 1 to a birth to an HIV uninfected woman. And so the updated prevalence of dolutegravir exposure preconception with neural tube defects is now 4 out of 596 for a prevalence of 0.67%. With the confidence interval 0.26 to 1.7%, and the 95% confidence interval still doesn't overlap with any of the other exposure groups. They have now expanded their surveillance to 18 sites, and by the end of March, they expect that they will have over 1,000 births with exposures to dolutegravir from conception, and will be able to more definitively look at this risk. And this table they provided shows you if what they might find in terms of prevalence and confidence intervals, depending on whether they see none, 1, 2, 3, 4, 5, 6, etc. New neural tube defects. So if there are no more neural tube defects, the lower confidence interval will then overlap the upper confidence interval for other treatment at conception, efavirenz at conception, and HIV uninfected women. If there's 1 more defect, then the lower confidence interval will still overlap with the other antiretrovirals at conception. And if there are more than 1, you can see that they will still remain outside of the range. So drug therapy in pregnancy is always a balancing act between benefits to the mother, risk of fetal adverse events, and often there are only limited data to make recommendations. So for dolutegravir, we have more rapid viral load decline, better tolerated, less expensive as the benefits for the mother, and now we have this potential signal for neural tube defect with preconception exposure. So presented at the same session was a CPAC computer simulation model evaluating a public health approach So they're assuming only one treatment can be recommended as first line for all women of childbearing age. And they use this using South African data over 5 years, so that gives them a population of 3.5 million women, 1.1 million children. And so they looked at dolutegravir, all women getting or switching to dolutegravir, versus efavirenz. So you have either you're going to go all for the benefits for the mother, or you're going to go all for the benefits of the fetus. This just shows you the model inputs, and I assume they'll have the paper out relatively soon that will have this in more detail, but just to go over a little bit, for dolutegravir they assumed a rate of 0.9% based on the presentations from Botswana. For efavirenz they used the Ford meta-analysis, which had over 2,000 exposures. The rate for efavirenz was 0.05%, and then they varied fertility rates, sexual transmission, perinatal transmission, and for looking at efficacy they looked at the single trial, which compared dolutegravir and efavirenz and showed 94% suppression with dolutegravir and 86% suppression with efavirenz. So what this slide shows you is the number of deaths for women, sexual transmission, perinatal infections, non-neural tube pediatric deaths, and for efavirenz benefit, neural tube defects, cumulative pediatric deaths, and children alive and HIV-free for dolutegravir and efavirenz. And in orange, you can see where dolutegravir benefits outweighed efavirenz, and in blue, you can see where efavirenz outweighed the dolutegravir. And basically, they said that there was 3.4 times more maternal deaths than pediatric deaths in this analysis. So dolutegravir-based treatment for all women would avert over 25,000 deaths among women of childbearing age and 5,000 new pediatric infections if you compare that to sticking with efavirenz-based treatment for all women, and this would be over 5 years in South Africa. And that these benefits may come at the expense of overall pediatric survival if the increased risk of neural tube defects with dolutegravir persists with additional data. However, there would be approximately threefold more deaths averted among women than pediatric deaths added with use of dolutegravir for all women of childbearing age. And they did note some limitations, and I think the most important limitation is that they only assessed an all or none approach, the public health approach, and did not assess an individualized approach with dolutegravir for some women and efavirenz for the other. And facilitating access to contraception or women's individual choice of treatment could lead to different results in this analysis for both women and their children. And they also noted that the single trial was not conducted in low and middle income resource countries where drug resistance, pretreatment drug resistance has been reported and would make efavirenz efficacy potentially less than in the single trial. So that then brings us to WHO, because the WHO presented their new guidelines at the meeting as well. So what did they recommend? So the new WHO recommendations for first-line treatment was that a dolutegravir-based regimen may be recommended as a preferred first-line regimen for all people living with HIV initiating treatment as a conditional recommendation, including adults and adolescents with moderate certainty evidence, women and adolescent girls with a very low certainty evidence because of this new data, and infants and children that have approved dolutegravir dosing. They also stated that dolutegravir would be preferred for second line and for post-exposure prophylaxis. And they then had, in addition to that recommendation, a note of caution for using dolutegravir in women and adolescent girls of childbearing potential, noting that there is this potential risk of neural tube defects that is being evaluated among infants, that if dolutegravir is started after this risk period for neural tube defects, after 4 to 8 weeks after conception, it is safe. and that dolutegravir can be used by women of childbearing potential who are using consistent conception, and that if a woman wants to get pregnant or is desiring to get pregnant, an efavirenz-based regimen is a safe and very effective first-line regimen to use. And then they talked about having national programs needing to consider the balance of benefits and risks, including fertility levels, contraceptive availability, pre-treatment resistance to NNRTIs, drug availability, and the toxicity profile. And they recommended a woman-centered approach that includes that women be individually talked to and offered contraception. So this is a little bit different than the all versus none public health approach that's been followed before and was looked at in that cost-efficacy analysis. So moving to studies on PMTCT, the first study comes from the Malawi Population-Based HIV Impact Assessment, or PHIA, and they used their PHIA data from 2015 to 2016 to measure the EID PMTCT cascade. And women were interviewed about their most recent pregnancy in the last 3 years, and then these endpoints as shown on the slide. So the analysis here was limited to women 15 to 49 who reported a live birth in the 3 years before the survey. This included 3,209 HIV uninfected and 302 HIV positive women. And there were some differences between the HIV positive and negative women. The HIV infected women were older, had a higher parity, and more likely to report that their pregnancy was unplanned. And this shows you the cascade. So in blue is the overall population, and in green is the HIV uninfected population. So in Malawi, the ANC attendance was over 99%. HIV testing was in over 96%. And of the HIV positive women that were identified, 97% were receiving treatment. Almost 80% of the infants were getting cotrimoxazole prophylaxis, but unfortunately, only about 50% of their infants actually got tested. Of those who were tested, 3.9% reported a positive result, giving a 3.9% transmission by self-report. And having an early infant diagnosis was associated with higher maternal education level that mothers had disclosed to someone and higher infant uptake of cotrimoxazole. There was a presentation from Lesotho on birth outcomes and HIV-free survival. They conducted an observational study that enrolled 941 uninfected and 653 infected women, almost all of them on treatment, seeking antenatal care from selected facilities between 2014 and 2015 in the context of option B+ in the country. So this slide now looks at birth outcomes comparing HIV negative to HIV positive. And what you can see there is that if one looks at stillbirths occurring during delivery, that was more frequent in HIV uninfected than HIV infected, but stillbirth occurring before delivery was more common in HIV positive than HIV negative. There was more preterm delivery in the HIV positive women, no difference in birth defects, no difference in birth weight. And now comparing HIV unexposed to HIV exposed children, you can see, I think looking at the graph is easier than the table, that there was no significant difference in 6-week survival between unexposed and exposed infants, whether you include or exclude stillbirths. And the HIV exposed there is in the orange line, and the HIV unexposed is in the green line. There were a total of 8 infected infants for a transmission rate of 1.3%, with over half of that occurring in utero at birth, 0.8% positive at birth. And HIV-free survival was very good, 94% if you include stillbirths and 97% if you exclude stillbirths. So option B+ is working pretty well in Lesotho. Moving to safer conception, there were a number of studies here. The first study I want to talk about is a study that actually is a long-term follow-up of the PROMISE perinatal study. It is enrolling women who were enrolled in that perinatal study and received treatment and are now on lifelong treatment, and is planning to follow them up for 5 years. So this is 8 sites in 4 countries with continued follow-up. Most of these women are on Favrance-based treatment. And what they reported was a very high rate of unintended pregnancy at their last pregnancy, with significant variation between countries. You can see the highest rates of unintended pregnancy, in one case over 80%, were in South Africa. The lowest rates were in Uganda. And this matched up with the use of effective contraception. So if you look at the dark blue bars, which is long-acting reversible methods, the most effective, you can see that South Africa had the lowest rate, 10%, which matches up with their unintended pregnancies. But of all of the countries had less than 25% of women using LARC methods. And unfortunately, women with viral load over 1,000 were actually less likely to be reporting that they were using effective birth control. So that brings us to a safer conception clinic demonstration project that was done in South Africa. And this is a clinic that was set up for adults who were trying to conceive in discordant partnerships. And this is a dedicated safer conception clinic. All patients here get HIV counseling and testing, STD treatment, viral load monitoring and contraception if they want it, and then a number of tailored approaches which include treatment of the infected individual, timed condomless sex, self-insemination if an HIV uninfected man, voluntary male circumcision, and PrEP. They had monthly counseling sessions. They enrolled 334 women. 87% of these were HIV positive, 192 men, 69% HIV positive. And you can see that even though a significant proportion of these HIV-infected individuals were on treatment, not all of them were suppressed, particularly in the men under 50% were suppressed despite being reporting being on treatment. So they had almost 3,000 visits with a large number of couples, 88%, having multiple visits. They had a median of 4 months before they were given the go-ahead to start to try to conceive. So, for example, they wanted to be sure that the HIV-positive partner was undetectable. So in blue, you can see HIV uninfected women, and in red, you can see HIV positive women. There were 98 pregnancies in 88 women, and you can see that HIV positive women were 52% less likely to conceive than HIV negative women, and the median time to pregnancy was 0.8 years for uninfected women compared to 2.1 years for HIV positive women. And decreased fertility despite treatment has been reported by others in HIV positive women. 17% used self-insemination, 83% most used timed condomless sex. 67% of the negative partners came in and were retested during follow-up, with women coming in far more frequently than men. This shows you pregnancy outcomes: 67% delivered, 4% ectopic, 21% miscarriage, 5% still pregnant. PrEP was used by over 50%. 87% had viral load less than 50, 99% less than 1,000 when at the time they got pregnant. And 87% had diagnosis done, and you can see there were no infections in any of the infants, and importantly, no infections in any of the HIV uninfected partners. So this worked pretty well. Moving on to infant diagnosis and HIV testing. The first presentation comes from the EGPath Unitaid Point of Care Test Implementation, which is being done in 9 countries, and they compared pre and post point of care intervention data. Now they had several different kinds of sites. They had standalone sites that all of the samples came from that site to the point of care testing machine. In order to expand access, they had hub and spoke networks. So spoke sites were within just a couple of miles of the hub site, and the spoke sites would send their samples to the hub site for testing. And they also had potentially multiple entry points in a point of care where a point of care test was done, where other clinics were there, like a pediatric treatment clinic or a maternal child health clinic or a nutrition clinic, etc. So pre-intervention data, which reflect conventional early infant diagnosis, which is usually dried blood spots sent to a central lab in the country, was done retrospectively. They did register data evaluation. They had over 2,800 tests from over 2,800 HIV-exposed infants from 96 sites. Post-intervention data was prospective from all point-of-care sites and included 19,000 tests from over 18,000 HIV-exposed infants. And so the first thing they compared were a number of different endpoints between conventional and point-of-care EID, including median turnaround time to result return, that the results were received within 30 days, the percent of infants started in treatment within 60 days, and the median turnaround time from sampling to treatment start in the infected infants. And you can see across the board, the point-of-care tests were significantly better than the conventional tests. So, for example, the turnaround time was 0 days versus 55. Results were received by caregivers in 98% versus 19% with conventional. Treatment was started 92% versus 43%, and treatment was started at 0 days versus 49 days. They also compared the hub sites to the spoke sites for the same parameters, and you can see that the spoke sites were significantly longer than the hub sites, not unexpected since they were sending the samples to another site even if it was the same time. But if you look at the time parameters here for the spoke sites, it's still significantly better than the conventional EID. For example, 2-day turnaround versus 55 days, 96% results received by caregiver compared to 19% with conventional. And then they looked at the entry point. And so if you look at the yield, the number, the infection rate by entry point, you see that the point-of-care EID appeared to be particularly beneficial for alternative entry point testing, such as the pediatric inpatient and outpatient wards, where the infection rate was 15 and 18% compared to PMTCT clinics, which had a rate of 3.2%. That despite the fact that most of the testing was done in the PMTCT clinics. And children presenting at these endpoints are often in an advanced stage of illness, and starting treatment rapidly is important, and thus the rapid turnaround that you get with point of care is even more important among these infants. There was a general presentation that talked about the fact that the group that we're trying to reach to diagnose today is a very hard to reach group, a very heterogeneous group. So, for example, the majority of new infections are occurring in women who don't access ANC, women who have acute infection and seroconvert after an initial negative test, and women who drop out. And that there's an unmet need for children being missed in very high volume sites like outpatient department, asymptomatic children who don't come to the health facility, and then adolescents with complex behavioral challenges that mean heterosexual transmission may occur. And so they talked about the fact that you need an optimal mix of testing strategies to maximize identification. And they talked about low and high volume and low yield and high yield. So, for example, nutrition and TB clinics have a low volume but have a potentially very high yield. Similarly, for inpatient testing, Index testing, where you have an adult that you know is positive and you're testing those children, is underutilized and has the potential for both high volume and high yield. Outpatient, again, potential for high volume and yield. And community testing has generally a low yield and a very high volume. And so with community testing, it might need to have some screening to look for HIV risk. Otherwise, you have massive volumes of tests being done. The recommendations made was that we need to be more strategic, that you need to look at the right texting mix for your context. Scale up underutilized strategies, in particular inpatient and outpatient testing, improving index testing, adopt a comprehensive approach to case finding, and improve coordination. There were a number of presentations on PrEP. So this first presentation is looking at PrEP offered integrated into maternal child health and family planning services in Kenya, 18 sites in Kenya. 21% of women seen here opted to receive PrEP, and they looked at factors associated with decline or acceptance. So if you first look at PrEP uptake by patient characteristics, PrEP was more likely to be uptaken by women who had a known HIV positive partner, who were older than 24 years, and those who were unmarried. If you look at PrEP uptake by family planning method, you can see that there was a higher percentage of PrEP use, that's in the orange, in women who are using oral contraceptives and implants than those using injectables or other methods. Reasons for declining PrEP in women who were found to be at HIV risk on questionnaire. The primary reason was the need to consult partner, but I've circled here low perceived HIV risk. So even though these women had risk, 26% thought that they were not at risk. And factors associated with acceptance of PrEP are shown here: prior diagnosis with an STI, forced sex, intimate partner violence, don't know partner HIV status, older age, condom use, and oral contraceptive use. So now they also looked at clinics that were antepartum clinics and MCH clinics looking at pregnant and postpartum women. So this is looking at 16 sites in Kenya. Again, 21% of the women offered opted to get PrEP. The PrEP uptake by patient characteristics were very similar, with just the added fact that postpartum women were more likely than pregnant women to take up PrEP. Reasons for declining, again, I've circled here. 35% of these women who had HIV risk thought that they were not at risk. And factors associated with acceptance of PrEP are relatively similar to what I just showed you before, with the added fact that women were more likely to take PrEP postpartum than during pregnancy. This is a study from Zimbabwe where they offered PrEP in one urban family planning clinic and one rural youth center. They had healthcare worker training and preparation, 2 weeks training for treatment because they weren't providing treatment, training on PrEP. They also did client outreach and enrollment by increasing client awareness by having group education in the waiting rooms. They did HIV screening and risk assessments. This shows you the risk assessment tool that they used. And in contrast to what we saw in Kenya here, there was only 5% overall uptake, with more uptake in the youth clinic, the rural youth clinic, 9%, than in the urban clinic, 2.7%. Most of those who started PrEP either had a known HIV positive partner or didn't know their partner's status. 26% were 16 to 24, so it was getting the youth group, and 20% were male. And this is another study from Kenya, and this was a demonstration project that had 3 clinics focusing on different key populations: female sex workers, men who have sex with men, and then adolescent girls and young women. Now this clinic, they screened people. People had to wait 2 weeks before they started to give time for lab tests to come back and give them time to decide. And they had monthly visits for refills and then every 3-month visits for follow-up. So this looks at retention by time after PrEP initiation. And you can see there's a big initial dropout between that screening and that 2-week visit in all of those groups. And then the biggest dropout is between starting and 1 month. Less than 50% came back after 1 month, particularly for the adolescent girls and young women. Only a third came back for their second visit. And this looks at reasons for dropout. For all of the groups, it included side effects, decreased self-perception of HIV risks, negative attitudes of healthcare workers, misconceptions, and then there were a number of different reasons for different key populations. And for the adolescent girls in particular, disclosure and community stigma and lack of partner support was important. And motivators for continuous use included having peer, guardian, or partner support, the access to combination prevention services, so not just PrEP, and an attitude of social responsibility. And particularly for adolescent girls and young women, having friendly services and positive healthcare worker attitudes were important. So we've seen several different models that had much different success in getting PrEP started. Moving to pediatric treatment and care. The first study is a retrospective evaluation looking at 12-month retention in HIV-positive children starting treatment at 42 clinics in Uganda, either starting treatment on the same day as diagnosis, 2 to 14 days after diagnosis, or more than 14 days after diagnosis. And so you can see the blue here is 2 to 14 days, the green is more than 14 days, the red is same day. Of these children, 91% stayed in care by 15 months, which I think is really good. 2% died, 7% lost to follow-up, and retention was 94%, 90%, and 89% respectively in the different groups with a p-value of 0.03. So there wasn't a decrease in retention if you start on the same day in children. This study looked at the effect of interrupting care on mortality in South Africa. Very interesting study, comes from IDEA Southern Africa, looked at 126 clinics across 6 countries between 2004 and 2016, over 46,000 children. They looked at children birth to 16 years, and the mortality in this group was 1,393. And there were 3 different groups. In green, you can see a group that started treatment and continued without follow-up, group 1. Group 2, you can see children who started treatment but then were lost in the first 6 months on treatment and then later returned back to treatment. And then you can see group 3, those who were on treatment for more than 6 months, then were lost and then returned to care. And so they looked at mortality in these 3 groups. And this is just to show you how they allocated person time. So a child starts treatment, attends visits, they didn't return, they had care interruption, they returned to clinic. So we have the time before care interruption and the time after care interruption. And you can see that those who were lost before 6 months of treatment had longer treatment interruptions, a longer percentage of time lost to follow-up, and more were lost in kids who were lost before 6 months than those lost after 6 months. And this was reflected in the risk for mortality. So this looks at the adjusted relative risk for death. And you can see that interrupting care before 6 months had a 3-fold increased risk of mortality than no care, but also higher than interrupting care after 6 months. younger current age, older age at starting treatment, adolescents, and starting treatment in the earlier treatment era. The next presentation comes from the CIPHER Global Cohort Collaboration. So this is 11 cohort networks that combined individual data through 2015, looking at children less than 10 as a proxy for perinatal HIV, and looking at those who started first-line treatment and then switched to second-line treatment to look at their outcomes. And they had a total of 3,555 children divided up by region, as you can see on the slide. 44% female, median age 8.4 years, median time on first-line treatment before switch 2.8 years, and you can see they were pretty malnourished, minus 1.5 weight for age Z-score. And this looks at regimens. So for those who were failing an NNRTI regimen, you can see that most started a lopinavir-ritonavir-based second line in the dark blue, but in Europe and the US there was more variation, as one might expect. Similarly, if you look at those who failed PI and then what they received afterwards, most started an efavirenz-based regimen in red, but again in the US and Europe there's more variety. So this looks at the median CD4 count over 2 years. So in red you have baseline, in green you have 1 year, and in blue you have 2 years for each of the different regions. And if you look at the red first, you can see that the CD4 counts at the time of second line switch varied significantly by region, with the median being less than 350 in Latin America, Asia, and Sub-Saharan Africa, whereas it was over 350 in US and Europe. And you can also see that almost all of them saw an increase in CD4 over time after they switched to second line, with the largest increase in those regions with a lower baseline. And in the US they were all pretty high, so they basically stayed the same. They didn't drop. And this looks at median weight for age Z-score over 2 years in the same kind of format, baseline 1 year, 2 year. And you can see that the median weight for age Z-score at second line switch was minus 1.5, varying from 0.05, which is in North America and Europe, to minus 2.5 in lower resource areas. And you can also see that the weight for age Z-scores basically stayed the same during follow-up, 2-year follow-up over all regions, suggesting that second-line treatment was not associated with much improvement in weight. And this looks at loss to follow-up. And the cumulative loss to follow-up was less than 5% in all of the regions except Africa, where it was a little bit over 7%. And this is actually much better than you see when you look at starting on first-line treatment. And mortality, finally, the risk of mortality was less than 3% at 2 years after switch in all regions except Sub-Saharan Africa, where the mortality, cumulative mortality, was 5.5%. And ending up with adolescents and HIV. The first study I want to talk about is a longitudinal cohort of adolescents living with HIV in the Eastern Cape and South Africa, has over 1,000 HIV-positive adolescents, and at baseline they did a record review from 52 health facilities, which allowed them to capture transfers between facilities. 54% were female, median age 13 years, and 30% attended 2 or more healthcare facilities. This is similar to a study from Croy, where there was a large number of mothers who switched care during pregnancy. So this looks at the HIV treatment cascade among these youth. So of the adolescents, in blue is horizontally infected, and in pink is vertically infected youth. So of the adolescents, 89% had patient files that were found, 93% had viral load data that were available, 76% had a viral load less than 1,000, but only 60% had, 59% had undetectable viral load. And if you looked at the youth overall of all of the adolescents, only 63% had a viral load less than 1,000, 49% undetectable, and only 63% of these viral loads had actually been measured within the past 2 years. And if you limited the analysis to those who had a viral load within the past 2 years, the undetectable rate was only 31%, so not so great. And predictors, so if we want to look specifically at viral suppression, you can see the predictors of viral suppression were the least likely to have viral suppression were being in older age, so older adolescents, adolescents who were in decentralized care, and adolescents who had more recently started treatment. This is the same cohort. They interviewed adolescent girls at baseline and at 1 year. They found that 17% of the girls that these HIV positive girls that they interviewed had a pregnancy, lifetime pregnancy, 6% incident pregnancy in the last year, 3% had multiple pregnancies, and the vast majority of these pregnancies were unintended. And in purple you can see the perinatal infection, and in yellow is sexual infection. In the girls who got pregnant, 44% had stopped treatment when pregnant, 23% mixed fed their child, 68% reported that they had been non-adherent to treatment in the last 3 days, 17% didn't know the status of their children, and of those who did, the transmission rate was 4.4%, and these girls were more likely to have dropped out of school. So this is a highly, highly vulnerable group of girls. Additionally, if you looked at the girls who had an incident pregnancy within the past year, they were more likely to have depression and trauma. And then if you look at postpartum sexual risk taking, comparing HIV uninfected, HIV infected, HIV uninfected women who got pregnant and HIV infected women who got pregnant, transactional sex was actually not different, other than it was increased with adolescent pregnancy, but there was an interaction with older partners in that HIV infected girls who got pregnant were more likely to have reported older partners. The next study looked at factors associated with adherence and viral suppression in youth in Kenya. This is a retrospective record review, and in this the mean age was 13.3 years, 53% were females, and of the caregivers, 56% reported attending a support group, 51% were HIV infected themselves with 99% on treatment, and 88% reporting good adherence. Whoa. Jessica, I just lost everything.
Okay.
No, it just came back.
Oh, all right.
Okay.
Oh, yeah.
Okay. Okay, here we go. Okay, so looking at factors associated with good adherence, 79% reported good adherence, 21% didn't, and factors associated with good adherence were viral suppression, that's not surprising, but caregiver adherence being good, the frequency of clinic visits being 2 months or more, so not that frequent, and region. And if you look at viral suppression, factors associated with viral suppression included good reported adherence, but again, having clinic visits that were 2 months or more apart, the region, and also regimen. If they were on second and third line, they were more likely to be suppressed and tenofovir-based treatment. This study looked at youth-friendly services in Malawi, and they compared standard of care to a number of clinics with different kinds of youth-friendly services. So you see here in light blue the standard of care all had HIV testing, STI management, and hormonal contraception, but the youth-friendly health services added integrated youth services, removal of access barriers, privacy from older adults, youth-friendly providers, and then the youth clinic 3 had empowerment sessions, and the last one had cash transfer. But they basically compared standard of care to these different youth youth-friendly services. And if you looked at HIV testing, condom use, and hormonal contraception as endpoints, you can see that the dark blue clinics had a significant increase in using these services at least once, as well as an increase in the mean times that the service was used. So regardless of what kind of youth-friendly service it was better than standard of care. This is a study from Rachel Vreeman and colleagues from Kenya that looked at an intervention for disclosure. So they did a cluster randomized trial in 285 child caregiver dyads at 8 clinics in Kenya. And they followed up for 2 months. And clinics were randomized to either standard of care or intervention, and the intervention included a narrative-based curriculum, a dedicated counselor, and facilitated peer support groups. And they found that at baseline, 32% of children reported knowing their HIV status, despite the fact that all of the children were on treatment for 4 years, with no difference between control and intervention. And when you looked at child-reported disclosures, the prevalence of disclosure increased significantly between baseline and 24 months in both control and intervention group, but much more in the intervention group with almost 16% difference. So there were both more disclosures and earlier disclosures for the intervention group, with the largest increase being at 6 months. And when they looked at mental and behavioral distress scores, for those who disclosed, they found an increase within 6 months, but then a decrease after 6 months. This is from Lucy Culver's group, and it's looking at the impact of a parenting program for adolescents on abuse and parenting practices. And this is a 14-session program. I'll discuss it in a moment on the next slide. And they did a cluster randomized trial with this parenting program compared to control sites which got a hygiene and hand washing program. And this was designed to reduce violence and produce economic strengthening, and included monitoring and praising teens, family problem solving, family budgets and savings, and safety planning. And they did a pre and post evaluation. And this was a 14-session program. It was run by a local NGO. It had weekly sessions. 10 were jointly attended by caregivers and the adolescents, and 4 were separated. And it was conducted locally in the community, in halls, churches, and outdoors under trees, with locally recruited community members who were trained by the regional NGO. And training was activity-based and emphasized program delivery using things like stories, songs, role-playing, modeling, and home practice. And this looks at positive intervention effects, and you can see there were many significantly positive intervention effects, including less violence, more positive parenting, more involved parenting, less poor supervision and corporal punishment, less depression, less parental stress, less drug use by the caregiver and the teen, more social support, more planning, less shortfalls of food, more family savings. Importantly, there were no negative effects, and there were a number of things that had no intervention effects. So Lucy then presented another presentation looking at the Sustainable Development Goals. And the Sustainable Development Goal 3 is the one that includes ending HIV. And she says HIV prevention in youth cannot be conceptualized within this SDG 3 alone, and that service provisions aligned with a range of SDG will be strongly associated with HIV prevention in youth. And she showed this by results from interviewing her adolescent cohort, looking at 6 different SDGs and their components, and showing how these youth had multiple areas in which they were at risk, including physical and verbal abuse, school dropout, high-risk sex, school failure, etc. So it wasn't just one SDG. And she says that interventions to meet SDG 3, all of the interventions from all of these different SDGs will be able to affect HIV risk for youth. So that if you're doing SDGs in the country to meet SDG goals, you can also be meeting HIV risk goals at the same time. And the last presentation comes from a spectrum modeling exercise. They used spectrum files from 141 countries from last year, and they compared what would happen using current track versus our fast track goals. And for current track, they just simply extrapolated from modeling increasing trends over time. And for fast track, they said, okay, we're going to meet the 2030 goals, and let's see where we'll be in 2020 if we meet those fast track goals. So our goal, our 2020 goal for Start Free was a 95% reduction in new infections among children 0 to 4 by 2020. And they estimated with the current track scenario, we'll have a 42% reduction, and with the fast track scenario, a 49% reduction. And our goal for Stay Free is a 75% reduction in new infections in adolescents by 2020. And with our current scenario, less than 30% for girls and boys, with the fast track scenario nearing 70%. And they conclude that it's possible that our 2020 targets are out of reach and that we must plan for longer term and more sustainable interventions to achieve and secure an AIDS-free generation over future decades. And this kind of goes with what we just talked about with meeting those sustainable development goals. If we can meet those sustainable development goals, we will also be doing HIV prevention. They looked at the life cycle of the aging epidemic and noted that with increased survival of perinatal children and a continued steady flow of new heterosexual infections in youth, by 2050, that 3.5 million adults living with HIV will include perinatal survivors and youth with sexual transmission. But that this kind of growth will differ in different regions because of the different youth group. And then they did a nice chart that looked at the top shows you perinatal infections age 0 to 4. The bottom shows you adolescent infections age 15 to 19 from 2018 through 2050 by region with different colors. And what you can see is that in prior years, about 50% of all pediatric infections come from Eastern and Southern Africa, and about 25 to 30% from West and Central Africa. But because of the youth bulge and changes in the types of infections that will occur, by 2050, it's estimated that West and Central Africa will contribute 48% of new infections among children and 35% of new infections among adolescents. And they also pointed out that Eastern Europe, Central Asia, and Latin American and the Caribbean are expected also to have an increasing input of infections. And I think that that's it. Yes.
Okay, great. Thank you so much, Lynn, as always, for a very thorough review of all of the major scientific findings presented at IAS 2018. So we'll field any questions or clarifications that the participants have. The first one is regarding the South African study that showed low viral load suppression, less than 50% among people living with HIV. And the question is, was the calculation based on those who did the viral load or those who were eligible? So generally, is there a relationship between viral load coverage and viral load result?
I think that that's referring to the Cascade of Care study. So there are two pieces. One, the chart showed you when you looked at the numbers in the chart, it reflected the suppression among those who had a test. But the text that I had underneath reflected suppression in the overall group, whether they had a test or not.
Okay, great. Thank you for the clarification. Any more questions or comments?
Hello?
Hi, Chewe. Do you want
Yeah.
to say something?
I just wanted to thank Lynne for a wonderful, wonderful overview, a lot of information. But I just wanted to go back to the point of care diagnostics and just where we are with children. The fact that we know how aggressive the infection is early in infancy, and we also know that when children are sick, if we pick them up when they are sick, mortality is very high, but more importantly, the impact also on brain development. And also, I think, Lynne, you've demonstrated in earlier studies the fact that you don't get full recovery when you pick them up when they are sick. So one of the questions I have for you is that if we have to move forward on a multi-pronged approach to finding children but optimizing their outcome, what would be your suggestion from the evidence that we have right now?
Well, I think that when we were at the WHO meeting a couple of years ago, there were a lot of concerns about point of care and whether that would inhibit routine testing, et cetera. I think that the data from the EGPATH Unitaid study, and they have actually a more intensive study that's ongoing, pretty much show that point of care is highly effective. Much better than our conventional testing. And so it seems to me that if one can implement incorporation of point of care testing, that we would do much better.
Okay, great.
I also have, I don't see any more questions on the screen, so I'm taking advantage of that. You know, the whole issue of dolutegravir and where we're headed in terms of the complexity around conception and when these defects are happening, and if it was true that we have a concern, I think that for me, it's actually about how are we going to come together as a global community around a public health approach that now starts to distinguish out if a woman is going to be pregnant, or adolescents who we don't even know when they're going to be pregnant, and this is a drug that would be good for them. I just don't know whether there's any thinking around how we might start thinking about our programs in relation to family planning, because a lot of programs are not working harmoniously with the family planning group. Does this give us the additional push to get more family planning people in the space?
Yeah, I totally agree with you. I think for years, you know, we've focused on HIV, and, you know, people have been, we've had problems with contraceptive availability in low and middle income countries for many years. Prior to HIV, during HIV, it's not changed. And I think that that's a problem. And I think that this offers us the opportunity to be able to pay attention to this. The primary cause of death of women is maternal mortality. It's deaths due to pregnancy. And it's about time that we began to focus on that as well. And while I know it's difficult, and people say, well, you know, how do we do a public health approach? How do we individually offer women contraception? I would just remind us that 20 years ago, people said that we couldn't bring antiretroviral drugs to low and middle income countries because they didn't have watches. So if we put the same effort that we had to bring HIV testing and antiretroviral treatment to low and middle income countries, if we put that same effort for contraception, we would have a benefit beyond HIV. We'd have a benefit in maternal mortality. So I would say that this is kind of a wake-up call for us in terms of let's try to integrate family planning into services where women are seen.
Yeah.
Thank you. Thank you, Lynne and Chewe. And I think related to that, we have a follow-up question that ties in very well to what you just discussed. And was there any specific examples or evidence that demonstrated the effectiveness of delivering integrated sexual reproductive health and HIV services for adolescents? And I think that's in light of the evidence that was shared around the proportion of unintended pregnancies among adolescents living with HIV. So
yeah, I don't think that there were, the only ones that dealt with integrated care are the ones that I showed, and I think it dealt with PrEP. So I don't actually think there's been a lot of studies looking at how to integrate sexual and reproductive health and contraception into adolescent care. It's a good area for further research. And I see there's a question about self-testing. And I didn't do a summary of those self-testing studies. It asks, were there presentations on self-testing in the context of partners and of lactating women and adolescents? There may have been, I don't recall specifically. There were a number of presentations related to self-testing, but I don't think that they were necessarily focused in this area. I do think there's been 1 or 2 studies looking at providing tests to pregnant women to bring home to their partners, showing that that has been effective, but I think those were relatively small studies.
Okay, great.
I see one more question. Impact of folate on dolutegravir in pregnancy. So folic acid has been shown to decrease the incidence of neural tube defects if you do folic acid supplementation of food. So in the U.S., after we did folate supplementation of flour, there was about a 50% decrease in the risk of neural tube defects. So in terms of the dolutegravir, in terms of folate use in low and middle income countries like Botswana, they do not supplement their food. And so what that means in terms of folate is that perhaps that populations that do not have folate supplementation might be at increased risk of having a neural tube with a toxin put in place, because neural tube defects are really a multi-step process. It's thought to be not just one thing happening. There's a underlying genetic risk, and then you put on top of that environmental factors. Now, if you look at folate supplementation and valproic acid, however, I do not believe that folate reduced the incidence of neural tube defects that were specifically associated with a known neural tube pathogen drug. So I think that in places like the U.S. and Brazil, in order to pick up if this is real, if dolutegravir is really associated with this, we would need thousands of more exposures than you would need in an area where there isn't folate supplementation. So one can't necessarily extrapolate from results in the U.S. and Brazil, for example, to a result in Botswana or Africa where there isn't folate supplementation. I hope that answered kind of your question.
Thank you, Lynn. And one more, a couple of more questions. One is, was there evidence shared to support the undetectable equals untransmissible campaign? And I think there was from the partner study. I do want to say that we also, it might be in the longer set of slides, but perhaps you could speak to that. But just to say that we tried to, kind of limit the scope of this to focus on pregnant women, children, and adolescents. But if you could speak to perhaps briefly to those results. And then there's a question about resistance to dolutegravir found among adolescents not adhering.
Right.
Since it's supposed to have a higher genetic barrier to resistance, is that worrisome?
So, at the meeting, my focus was women and children pregnancy, so I didn't attend a lot of the U equals U type presentations. There was a presentation on treatment in men who have sex with men that basically found the same thing that HPTN-052 found, which is that if you treat an individual and they're undetectable, whether it's heterosexual transmission or homosexual transmission, there doesn't appear to be transmission as long as the person is suppressed. I would like to say that we don't necessarily have the same evidence for breastfeeding. And the reason I say that is that in the PROMISE study, the publication by Pat Flynn this year in JADES, two of the transmissions, there were only 0.6% postnatal infections, but two of those infections were in women who had an undetectable viral load near the time of the presumed infection. And it may be that for breast milk, that first antiretrovirals get into the drugs in different amounts, and there's also both cell-associated and cell-free transmission. So U equals U may not be necessarily extrapolatable to breast milk transmission. Dolutegravir resistance. So yes, it is true. Dolutegravir has a higher genetic barrier to resistance. And is it worrisome with the adolescents? Yes, it's very worrisome, but it's interesting. Whenever we have a new drug come out, it's always the miracle drug that has no resistance and everything is going to be wonderful. But if you look in the literature, there are beginning to be more reports about dolutegravir resistance being found. So I do think that there's a higher genetic barrier, but I don't think that means that there are not going to be resistance. So I think it's not just worrisome for adolescents, I think it's worrisome for adults, and that we can't just assume that just being on dolutegravir means we don't have to pay as much attention to adherence issues.
Okay, great. I think that's about all. I don't see any more questions coming in. Once again, Lynn, thank you so much for an outstanding presentation. Really covered all of the main issues and evidence that were shared at IAS regarding pregnant women, children, and adolescents. We will share the presentation, the recording, and Lynn has also graciously prepared a much longer set of slides, but that we didn't have time to present during a short webinar. So all of that information will be provided to you through the community of practice and on our website. If you'd like to join and haven't and aren't a member yet, please send us your email and we will make sure to add you. And we look forward to having many more webinars in the fall. So thank you all for joining and taking the time to listen. And thank you, Lynn, for moderating and for organizing all of this information.
Okay, great. Thank you.
Thank you. Have a great day, everyone. Bye.